two things that you need to master the concept of Wilson disease. Number one, A, is this, that the amount of copper which we take through our diet, our food, our meal, that is much more than what we require. So naturally, to excrete that excess copper, we need a mechanism. So that's why there is normally a physiological mechanism is there to excrete that excess copper which gets inside our body, and that is done by liver cells, and this excess copper is excreted through the bile. And in the liver, this job is done by a protein which is found by a gene called ATP7B. Now ATP7B does two important things here. Once you take your food or meal, the copper gets absorbed into the GIT, comes into the liver cell. In the liver cell, this copper, some of the copper would be get bound with apoceruloplasmin, which apoceruloplasmin with the copper would form ceruloplasmin. The ceruloplasmin is the copper carrying protein in the blood. So this amount of copper which is getting incorporated into the apoceruloplasmin to make ceruloplasmin, that would be released into the blood. This is necessary portion. And the excess portion of the copper which the body feels unnecessary, that would be excreted through bile. And that would also be done through a ATP based cation channel, which is ATP7B. So ATP7B is playing important role you need to understand. One, it is binding the copper which they feel necessary, the body feel necessary, with the apoceruloplasmin to make ceruloplasmin, which get released into the blood, ceruloplasmin, copper transport protein. And the unnecessary amount, excess amount, would be released from the liver via the bile. Now what happens in Wilson disease, we all know that it's an autosomal recessive genetic disorder where ATP7B gene is mutated. So if ATP7B gene is mutated, its protein will also not do its proper work. So both the work which is normally done by a healthy ATP7B protein will be disrupted. What does ATP7B gene does? As I already mentioned, number one, it incorporates the apoceruloplasmin, the copper into apoceruloplasmin to make ceruloplasmin. So this job would not be done. If this is not done, ceruloplasmin with bound copper would not be released into the blood, understand, which contains the copper. So ceruloplasmin level would become low because copper is not getting packaged with apoceruloplasmin due to presence of defective ATP7B. So that's why ceruloplasmin is not made. So obviously ceruloplasmin level would become low. Another thing would occur, the excess copper which gets released by this ATP7B based channel, cationic channel, that would also not occur. So excess copper would start to stay within the liver cell, start accumulate within the liver cell, pile up in the liver cell rather than getting excreted by the bile. So progressively what is going to happen, within the liver cell, there will be too much of copper which will become toxic, the liver cells would die, and those unbound copper, they would get released into the blood. Now we all know that any unbound form of metallic ion is bad for us. Like that's why iron is bound with transferrin. I think in this way that metallic ions, when they are unbound, it's like the mischievous child, they can do a lot of damages. Similarly, these metallic ions, they do a lot of damages through Fenton reaction. They generates free radical. The free radical mediated damage occurs. Oxidative damage could occur to the surrounding tissue. That's why free metallic ions are bad for us. And that's why body always keep a carrier protein, kind of nanny-like protein, who would carry this mischievous metallic ions with them so that they don't do anything mischievous unnecessarily. So that's why you'll be seeing that free metallic ions are always carried by a transporter protein, like iron is transferrin, copper would be ceruloplasmin. Now what is happening, that the excess copper which is accumulating in the liver cells, because neither they can be excreted through the bile nor they could be excreted through ceruloplasmin, it would cause damage to the liver cell would die, and from the liver cell it would come into the blood in an unbound toxic form. And these things would get deposited in the various parts of the body. In the cornea, it would be deposited in the Descemet's membrane to cause Kayser Festival ring, KF ring. It would also be deposited in the brain, in the basal ganglia, in the globus pallidus and the putamen, which basically controls two things: your motor coordination of the movements and your mood regulation. So if those parts get damaged, there will be neurological manifestation as well as psychiatric manifestation. We call it neuropsychiatric manifestation. Obviously, initially, as I mentioned, the liver has been damaged, so the features could be features of liver failure, there could be hepatitis, cirrhosis, these features could be there. Plus, other than these three key organs, liver, eye and brain, eye also there could be sunflower cataract, there could be features of sclera, it could be jaundice, you can also see it in the physical examination. But other than these three key organs, the other organs which would be involved could be hematological system. There could be non-immune hemolytic anemia, the RBC would be hemolyzed. In the kidney, they can cause Fanconi syndrome, where tubules get damaged and amino acids get released. The skeletal system, they can cause premature osteoarthritis. So a lot of systems other than the three key, that is the liver, the initial which get damaged, neuro and the brain and the corneal, other things which also be involved by them. And coming to the diagnosis aspect is that you have to think in a proper context. So typically the manifestation would be in a young child or adolescent. The age manifestation, there's a 3 to 55. So there's a wide range of manifestation which can occur when a child or young adolescent is presenting with unexplained liver disease, or adult is presenting with unexplained liver disease with neuropsychiatric manifestation. You have to think about Wilson disease. You have to look for family history also, because this is an autosomal recessive disorder. And then for the test portion, if you can do LFT initially, liver function test. Liver function test, what would be getting, you'll be getting the features of abnormal biochemical test findings. Actually, there will be AST raised, ALT raised, these features would be there. Hyperbilirubinemia could be there, features of jaundice could be there, depending on the status of the liver damage. More important diagnostic findings are two. As I mentioned, that ceruloplasmin level would be low in serum, and urinary copper excretion would be very high for 24 hours. These are the two important findings. If these findings are inconclusive, then in certain cases you can go for liver biopsy. Now, liver biopsy, basically two areas are there. One thing, we look at histology. Another thing what you do is actually you check the dry weight of quantitative estimation of the copper in the liver biopsy. It should be more than 250 microgram per gram of dry weight. But it is nowadays done rarely, because usually what we can do that in a context of the patient, if we go for these two tests, that is the serum ceruloplasmin level and urinary copper excretion, most of the cases it is resolved. Otherwise, you can go for histological confirmation, particularly the gram per gram of dry weight, and also you can go for genetic testing that is also available in certain advanced setup. And other things we can also do, like MRIs that have to do. So the basic idea is this, that this is a inherited disorder of copper metabolism. Copper intake of our body in diet is much excess than our need. That excess copper needs to be physiologically is excreted by our body through an important protein called ATP7B, and this is controlled by ATP7B gene, which does two important facts. They package the copper into apoceruloplasmin to make it ceruloplasmin. This portion gets released into the blood in form of ceruloplasmin, because this is the amount of copper which would be there in the blood when we need it. And the unnecessary excess amount of copper would be excreted by the bile. When ATP7B gene gets mutated, neither of this job is done. So your ceruloplasmin is not formed. So that's why ceruloplasmin level would be low. In case the apoceruloplasmin gets released into the blood, that apoceruloplasmin would be quickly degraded, you understand, because they would only be staying there if apoceruloplasmin is bound with copper, forms ceruloplasmin, that only stays in stabilized form in the blood. And ceruloplasmin is not formed in this condition. That's why serum ceruloplasmin is typically low, and you get increased urinary copper excretion, because all this unbound form of copper which is released into the blood, the body would try to excrete them through the urine, and that's why in this process kidney would also be damaged, you understand. And other interesting aspect is that this condition is also known as hepatolenticular degeneration. Then other than liver, this part of the basal ganglia, global pallidus and putum, which are called this lenticular nucleus, they also get damaged to cause neuropsychiatric manifestation. These are some key aspects I feel about Wilson disease. I'll continue about them in the future sessions. Thank you so much.